Which Donna, would you please introduce yourself?
My name is Donna LaChapelle. I'm Ojibwe, Dakota, and I grew up here in Minneapolis, not far from the clinic. So I haven't left home. You know, I'm still here, and I just am one of the elders in residence at NACC, and I'm glad of my place here, and I'm glad to share what I've learned on my journey. So thank you.
Thank you. And Michelle, could you introduce yourself?
I sure can. Hi, everybody. I'm Michelle Corcoran. I'm the nurse supervisor for the MAT program at NACC. Welcome. Thanks for joining us.
And Tina?
Hi, I'm Tina. I am the HIV case manager at NACC.
Thank you. And Beth?
Hi, I'm Beth Ryan, and I'm a Project ECHO coordinator.
Thank you. And I'm Kari Rabi. I'm a family practice physician and addiction medicine physician here at NACC and head up the MAT program. So we're going to go and we are happy to have Jace Gilbertson here today to talk to us. And I'm going to go ahead and start my slides. Let me start at the end. We'll go back to the beginning. Okay. All right. So today we had a prayer and land acknowledgement from our elder residents. Donna, thank you again, Miigwech. I'm going through the introductions and agenda, actually, and the Zoom guidelines, and then Michelle will be going through our announcements. Jace will be doing our Directacting today, chronic hepatitis C management in primary care, and if there is time, which there rarely is, Dr. Grain will hopefully be doing a case presentation for us, and then we will close. So of course, we are very familiar with Zoom at this point. But just in case, please introduce yourself in the chat function, your name, title, organization, and email. And you can also right click on your image on your screen and rename yourself so we can know who you are. We really do like to see your faces. So even if you're eating, we'd like to see you. Turn your camera. It just makes us feel like we're more in the same spot. Please mute your microphone when you're not speaking. We may mute it for you if there's sound coming from your microphone. So please don't take offense. You can use the chat or hand raise function for attention, and please no protected health information. Michelle, could you please do our announcements?
Absolutely. So we meet on the first and third Wednesday of every month from noon to 1. Like Dr. Rabi said, it's fine to have your camera on, even if you're eating. We know it's lunchtime, and hopefully people are enjoying, their afternoon coffee, snack, whatever. Upcoming sessions. So in September, we've got wound care. And so Genevieve Utley, who is with Hennepin Healthcare for the Homeless, I believe, is going to be talking with us about wound care, which will hopefully include photos. On the 15th, we're going to have Kaz Nelson. She is a doctor, and she's going to be talking with us about borderline personality disorder, which, I'm sure is going to be really helpful information. So let's see. Some other echoes, viral hepatitis echo. So if you're interested in what we're talking about today, you might want to jump in on Hennepin's viral hepatitis echo. They really get a little bit deeper into hepatitis. So that's on Tuesdays, and then they have an integrated opioid and addiction echo that they do on Thursdays. And then you can reach out to us, reply to the email that you get, reminding you of sessions and things like that, or you can email Beth Ryan there at hcmed.org. Yep, that's her. Case presentations. As you know, we rarely get to these. However, even if we don't have time, if somebody sends us a case presentation, we can talk about it one-on-one, or just kind of hang on to it and keep trying to get to it. Either way, feel free to send something in that you want to talk about, or particularly difficult or wonderful encounter with a patient. We would be happy to discuss it.
And we can always make
And do we have any other? Oh, continuing education. So this is an important one. Generally, we offer CME credit, CEU credit for these sessions. So if you, in the chat, tell us who you are, give us your email address, you're going to get a survey after the session. Completing that survey basically lets us know that you attended, and then the CME department a couple times a year sends out kind of those certificates stating that you attended. If you're watching this as a recording, you are not eligible for any CME or CEU credit for that. Sorry. And that's it.
I'm going to turn it over to Jace to start his presentation.
All right. You guys see my slides all right?
Yes.
Hear me? Okay. All right. Sounds good. Well, like Dr. Robbie said, I'm Jace Gilbertson. I am a registered nurse and I'm the nursing manager at the Native American Community Clinic. I'm also a third-year DNP family nurse practitioner student at the University of Minnesota. And today we're going to go through managing hepatitis C in the context of primary care. I do have a lot of slides today, and I'm going to try my best to whip through them. So I believe you guys will have access to these slides after the presentation. So there's some good information in there, but I may not cover every point. So if you have any questions, please leave them in the chat, and one of my colleagues at NACC can call those out to me. Let's see here. First off, I have no financial interest, relationships, or conflicts of interest to disclose. I do use brand name medication names throughout the presentation because there are no generics available, but again, no financial conflicts of interest. Here's our learning objectives. So throughout this presentation, the treatment recommendations that I make do come from the AASLD IDSA's 2019 guidance for hepatitis treatment. And this is available at the end of the slideshow. There's a link to this guideline. It's a great resource. It's very long, but there's some great clinical information in there. So to start, I just wanted to touch on some hepatitis C epidemiology and some trends we've been seeing with the opioid epidemic, and then just to go over a brief introduction to the importance of treatment. So in 2019, the CDC published their 2019 viral hepatitis surveillance report. And in this report, we saw that there's 3.2 million Americans living with chronic hepatitis C that has not been treated. We've seen actually a pretty steady incline in cases of chronic hepatitis C since about 2010. We had seen a decrease for a while from 1990 to the early 2000s. So trending upward. Within this data, some kind of disturbing trends that we've been seeing and some widening disparities, particularly among American Indian and Alaskan Natives. We're seeing that American Indians are about 2 times as likely to become infected with hepatitis C compared to non-Hispanic whites. They're also 3 times more likely to die from complications related to untreated hepatitis C. And then we're also seeing a trend of these new hepatitis C infections, which used to primarily impact kind of the baby boomer generation, people who received blood products back before 1990. But now we're seeing this cohort of young individuals, like ages 20 to 40, that have reported a history of injection drug use, making up the majority of new cases. And we've seen kind of an exponential growth since 2010. And, you know, the correlation to that is the beginning of the opioid epidemic, an increase in higher risk injection practices that have resulted in these cases. Now, the importance of treatment for hepatitis C is that without treating the disease, you can have some pretty serious complications. 20% of chronic hepatitis C cases will progress to full liver cirrhosis. So that's near failure of the liver. 10% of cases will develop end-stage liver disease or liver cancer. And then about 3 to 4% of chronic hepatitis C cases do require a liver transplant. And without one, would inevitably die from the complications of their hepatitis C. So pretty devastating illness if you don't treat it. Our liver is a vital organ to our body, and without it, we don't do so well. So this is just kind of a graph of that data from that CDC report. That top line there represents American Indian and Alaskan Native populations. That blue, I'm colorblind, so I'm probably saying totally the wrong colors, but the second line there with the triangles is white non-Hispanic. So as you can see, from 2004 to about 2010, there's still some disparities, but definitely kind of trending similarly. But around 2010, the onset of the opioid epidemic, you just see an exponential growth and widening disparity for American Indian and Alaskan Natives that continues now through the data we're seeing in 2021. There will be a new report coming from the CDC this year, so it'll be interesting to see what that shows. These trends are similar for Minnesota. This is from Minnesota Department of Health data in 2018. That left bar graph represents the case rate for American Indian and Alaskan Natives per 100,000 people in Minnesota. Compare that to the bar all the way on the right. It's your white non-Hispanic folks. You can see just in my opinion, just horrific disparity in who's being impacted by this disease. So a little bit of history of how we at NACC got into treating hepatitis C. With our opening of our medication-assisted treatment program with Dr. Robbie, we started seeing an influx in new hepatitis C cases among young adults coming into us. We, around this time, because we were noticing that, started implementing clinic protocols to increase the frequency that we were screening for hepatitis C, as well as other infectious diseases. So any patient coming in for our MAT program does get a full battery of lab screening for these things. And we do see probably the majority of our new cases of hepatitis C impacting this subset of our patients. We also, during this time, then started developing our harm reduction services with syringe exchange, Narcan distribution, and safer use education. So our previous way we managed hepatitis C is that we would make a referral to hepatology or liver specialists or to infectious disease, and then they would manage that. However, after a lot of nursing care coordination, I started doing this, making appointments for people, scheduling transportation. We still saw a near zero completion rate of treatment or even starting treatment, just because of various factors, social factors, transportation, access, missing appointments. People would get fired for missing appointments. And so we just saw, this trend of they would come and engage with us. We try to refer them again and again, and they were still sitting with active hepatitis C. And, we've kind of felt like we were just spinning our wheels. So at about the end of 2018, Dr. Robbie partnered with a local infectious disease provider, Dr. Frank Rame, with Alina, and we began building our capacity to begin treating hepatitis C in our clinic. We treated our first patient successfully in August of 2019, and then we've kind of been going ever since. Obviously with COVID, there's been, changes in our ability to do that, but we have began ramping up again and have been treating quite a few cases. So that leads us to the question of who should be treated for hepatitis C. With the new technologies and medications, really all patients with chronic hepatitis C should be treated because it reduces the risk of those adverse liver outcomes and prevents further transmission. The goal of the treatment, like I said, is to reduce those risks and the risk of death. Studies show that when you do clear the hepatitis C virus, you reduce your risk of liver cancer by more than 70%, and you reduce your risk of death by more than 90%. So really important if they have it to treat it. Now going into the treatment timeline. So back in about 1991, we had our first therapies available to treat chronic hepatitis C. This was our interferon or PEG interferon therapies that you've probably heard of. It was horrible. There's this quote here from Dr. Gaffney Adams. The treatments at minimum took 48 weeks, sometimes a lot longer. The side effects were horrific, comparable to chemotherapy. People said feeling the worst that they've ever felt. And then after that 48 weeks, there was about a 40% chance that you would clear your hepatitis C. And so that lasted for about 25 years, and really gave hepatitis C treatment kind of a bad rap within the community because people were very afraid, and rightfully so, of the treatment. So now fast forward to 2021, we now have 8-week treatments with our new medications. They're 95% effective, and they have very minimal side effects. They're very tolerable for patients, and they're easy to manage from a primary care perspective. So like I said, those traditional antivirals like interferon therapies have been mostly phased out with this new class of medications called direct-acting antivirals. The first one being the HCV protease inhibitor approved by the FDA in 2011. These were a new class that really had minimal side effects. They were accessible and easy to use. And now they've been building off this technology to make it even easier. And we have now 19 FDA approved hepatitis C drugs that are currently available in this class. The most common would be your Mavorite, your Harvoni, Epclusa, and Vosevi. The regimens are really well tolerated and have really short therapy duration. So again, you're cutting about 40 weeks off of your treatment time. Average treatment is about 8 weeks. So this is just a comparison of the success rates of treatment. All the way on the right is your direct-acting antiretrovirals. That is your new Hep C medications compared to your interferon therapies. And as you can see, far more successful. You're not setting your patients up for failure and a painful 48 weeks of treatment. So now we have these medications, and we know that they're easy to manage and they're easy for patients to take. And so there is now a shift to begin treating hepatitis C in primary care. However, I think there's some catch up that we need to do because many medical professionals haven't had the training to manage these medications. When we look at studies of cases of uncomplicated treatment of hepatitis C in primary care, their outcomes are near identical to those of specialty care providers. And really, that's not to say we don't need our specialty care providers, but we can use our specialty care providers to treat the complicated cases, which I'll talk about with co-infections and severe liver disease. And really the exciting thing about this is once we begin training providers to treat hepatitis C, you can begin implementing in your own practices. So at NACC, this is kind of what we've done, using a more harm reduction approach to tailor to our community to make treatment more accessible. And I think this will help, reduce some of those barriers to access and hopefully work towards, narrowing that gap we're seeing in new cases. So I'm just going to do a brief overview of, screening and diagnosing hepatitis C. Some of this may be reviewed for some people. So in 2020, the CDC published new guidelines for screening for hepatitis C. They recommend that any adult age 18 years or older, regardless of the presence of any risk factors, should be screened at least once in their lifetime. And that is a change. They used to just say anyone born, before 1990 should get screened. So they're kind of widening that because we're seeing this kind of explosion of new cases among young adults. They also recommend that all pregnant women should be screened at least once with every pregnancy, and then recommend an increased frequency, every 3 to 6 months at NACC. If somebody has risk factors, we do every 3 months usually. And that's for any risk factors for transmission, which can include injecting drugs, sharing use supplies, rigs, straws, pipes, and then any exposure to blood or bodily fluids, mucosal exposure. So the general screening test that we use for hepatitis C, the hepatitis C antibody, this is what's used kind of as the first line test. This is your test that's most often used in like community-based rapid tests. And this is just checking for the hepatitis C antibody, checking for if your body has had any exposure to the hepatitis C virus. It doesn't tell us if you have a current infection. It just tells us if your body has come into contact with the virus. So if you have a positive antibody test, you do need to follow it up with your hepatitis C viral load. Now, this test is what checks for an active infection It's actually checking for the viral RNA, so the genetic components of the virus. So if you detect that, then you detect that there is a active, acute, or chronic infection of hepatitis C in the body. Most lab-based hepatitis C testing will just automatically reflex to this viral load. So like at NACC, if we have a positive antibody, it'll automatically process a viral load because we do want to know what that is. So this is just the algorithm from the CDC. This can be helpful for people who don't have a lot of familiarity with the antibody versus the viral RNA and kind of how you can diagnose the infection. So the diagnosis of hepatitis C is a little bit tricky, and it gets a lot easier once you start working with it. It's really all based on time and the presence of that viral load. So if you have a patient who you have no history of hepatitis C, they come in and it's their first time they have a positive antibody and an elevated viral load, we usually consider that an unspecified hepatitis C infection. We know that the hepatitis C virus is there, but we also know that some patients will just spontaneously clear their infection without treatment. It's kind of this acute phase when they're newly infected. And so we closely monitor these patients to see what the outcome of their infection would be, whether they clear it or whether we need to move on to treating the infection. This new positive, you also need to consider an acute infection is if you have a patient new positive that's feeling really ill, having symptoms of liver dysfunction, yellowing skin, just looks ill, and it's their first positive, really check their liver function, because you may be having an acute hepatitis C infection where you would see just an exponential increase in their liver function tests, and they may need supportive care in a hospital. It's pretty rare. I don't think I've maybe seen one at NACC, but usually we don't. It's an asymptomatic process. So when you get two hepatitis C RNA viral loads that are separated by at least 6 months apart, that is confirmatory for a chronic hepatitis C infection. If you have a positive antibody and then that viral load is negative, that means they've had an exposure, but they don't have any active virus. We consider this a history of hepatitis C. That could be whether a spontaneous clearance or it could be from a treatment too. So this is just an example of the history of hepatitis C. You can see here, there's a positive hep C antibody that became reactive. That reflexes to that second part there. You see HCV RNA, that's checking for your viral load. This patient had a non-detected viral load, which means they have had a history of hepatitis C, but they do not currently have the infection. I think the important thing for patients that clear the infection is there is a myth that once you have the antibody, you are immune from future infections of hepatitis C, and that is unfortunately not the case. Patients who clear either spontaneously or with treatment are still susceptible to getting the virus in the future. So really providing good education about future harm reduction approaches if somebody's still using and ways to prevent transmission is important. So just briefly on spontaneous clearance, this is something, it's fairly rare, but we do see it quite often at NACC. And the reasons why people do this, they're still kind of looking into. There's some theories, whether it's genetic or otherwise, something like that. So we see it happen about 10 to 20% of cases, and then about 80 to 90% of cases will progress to a chronic infection and they'll hang on to that virus. So we do monitor these patients about every 3 months to determine their outcome. Also gives us the labs we need then once we confirm a chronic infection to pursue treatment. Some of the associations with clearing is hepatitis B infection. If you have hepatitis B, there's an increased incidence of clearing hepatitis C because the two viruses kind of compete with one another. And so it's just something, if you have a patient who clears hepatitis C but is still having some liver dysfunction or not feeling great, considering hepatitis B as a potential underlying cause, and then again, providing that education. This is just an example of somebody with an elevated viral load. If you have 2 of these 6 months apart, you can confirm a positive hepatitis C, a chronic hepatitis C infection. All right, so you've confirmed a chronic diagnosis with your patient. They've had 2 elevated hep C viral loads 6 months apart. They're coming in to see you or into the clinic to talk about treatment. This initial hep C treatment visit is kind of a big visit because there's a lot of labs and things. This is kind of the outline. We do a full history, we do a lab assessment, and then we try to do some good patient education and care coordination to prepare for treatment. So history, the biggest thing we want to know is their date of first positive if we're able. So if they haven't had these positives within your system, it's really important to get releases of information signed, or you can also call the Minnesota Department of Health. Their hepatitis C division they're wonderful to communicate with, and they can help you determine if there is a history, because all hepatitis C labs are monitored by the state and each county as well, or Hennepin County for sure. So if they knew they had it in jail, that they were positive, you can try to sign a release and try to get those records, but you do need the physical lab evidence of those 2 viral loads separated by 6 months with the prior authorization to be able to get the medications approved. So that's very important. And if you don't get it on the front end, it's kind of hard to get it on the back end. So, and then we also want to determine if they've ever been treated before. This is with some of the newer medications, or if they've had a history of receiving interferon therapy back, in the 90s. If they do have a treatment history, we do recommend that these patients be treated with specialty care. It gets a little more complicated when their body has had these medications in there because there's susceptibility to resistance. So we want to make sure they're treatment naive to be able to treat in primary care. And then we do a good risk factor assessment. What are their current risk factors? What is their risk for transmission? We get into a lot of their current use. If they need, it's a good opportunity for education and offering services. And then educating about their future risk once they are treated, and about where they could potentially pick up hepatitis C in the future. And then we do kind of a regular medical history, looking at comorbid conditions that may impact treatment, any other liver diseases, kidney disease, any cancer, history of transplant. Those are things you would probably want to consider a referral to specialty care for, like hepatology, because it does get far more complicated when you have those conditions. If you have a patient who is able to bear a child with you, you do need to discuss the risk of pregnancy. That all these new medications have not been studied in pregnancy, and there is a theoretical risk to a fetus and with breastfeeding. And so talking with your patients about their plans during treatment for contraception and to prevent those risks is very important. We usually do a urine pregnancy test at this visit, just to confirm it's useful for the prior authorization, because they do ask to verify their pregnancy status. Important to note, some of the antiviral regimens are contraindicated with ethinyl estradiol products. So these are your combined oral contraceptives. It's in some of them, so you do have to look for that. And if they do have that, planning for if they need to transition to an alternative contraceptive method during treatment. We also do an infectious disease history. Do they have a history of HIV and or hepatitis B co-infection? And then have they received treatment, or are they on treatment for any of those things? And then really talking through social history. This is where the nurse goes in and determines their readiness for treatment, and the provider does this as well. But checking their housing status, what's their insurance status? These medications cost $40,000 to $50,000 a month. And patients often need 1 to 3 months of treatment. So insurance does cover them. So it's important that you get linked up to that in that initial visit. And then we talk a lot about transportation, ability to get to appointments. How are we going to get a hold of the patient? How are they going to get a hold of us if there's any issues? Where are we going to deliver meds? Kind of planning for how we make this therapy the most successful. And we at our clinic use nurse care coordinators to do this work. So this is the initial battery of labs that we do. Like I said, this first visit is pretty intensive lab-wise. I'm not going to go through all these, but basically you're going to verify their hepatitis C status, check that viral load. We do a hepatitis C genotype, which I'll talk about in a few slides. We check their liver function. We want to make sure their livers are healthy enough to tolerate the therapy. So we check a complete metabolic panel, looking at their LFTs, their bilirubin, their renal function, and electrolytes. We also look at their blood count and their INR. With liver dysfunction, you start seeing impacts to platelets and INR and sodium when you start getting a severely fibrosed or cirrhosed liver. And so this is the way we screen for that. We do a non-invasive assessment of liver fibrosis with the FibroSure blood test, and I'll talk about that as well. You do need to check and make sure that these patients' livers are healthy prior to starting treatment. So this is how we do that. And then we do check their co-infection status, ruling out HIV, making sure they don't have hepatitis B, and then checking for immunity to hepatitis B and A and offering booster shots at that time to protect the liver. And then we do order other testing as needed, considering risk factors. We do a lot of full STI screens. If somebody's unsheltered or unstably housed, considering risk for other infectious disease like tuberculosis. For anyone able to bear children, we do a urine pregnancy test. And then for anyone that is in treatment, and we also run a urine toxicology because you'll need that for the prior authorization. And important to note that most of these labs need to be done within 6 to 12 months of submitting your medication request. So just to go over the types of ways we can verify liver fibrosis, there's kind of three main ways. The gold standard is the liver biopsy. This is obviously the most invasive, and it's really not needed for treating cases of hepatitis C, especially in primary care. Then your second kind of less invasive method is the imaging. There's non-invasive imaging like the FibroScan or elastography. This is kind of the preferred method. It's the most accurate to assess for fibrosis. However, these machines are super expensive. There's not very many around Minneapolis. And so it's kind of inaccessible. And especially for patients in our clinic, if they're not going to the specialty care appointment, it's also hard to get patients to go to some imaging appointments. So with non-complicated cases of hepatitis C, you can really use these blood tests. So this is the FibroSure, in addition to some blood test calculations with the FIB4 and APRI, which I'll get into. And a combination of those three can really help you get a good look at the liver, see what's going on without really having to get into the liver by cutting it open. So really important during this initial visit is talking about compliance. We want to make sure that these patients are in a good spot to take medications 1 to 2 times a day for at least 8 to 12 weeks. They should be in a place where they can take their doses around the same time each day, and to really avoid missed doses. Really, 1 to 2 missed doses during therapy is fine. Once you get over 2 missed doses, you really get worried about resistance and treatment failure. So talking with that about the patients, insurance companies usually don't like to cover these medications twice for people because they are so expensive. And so making sure they're in a good spot to do the treatment. And if they're not, kind of planning, whether it's use or housing, planning for those things and kind of setting up a care plan to get those things done before, we start this process. Also, we talk about side effects, the most common being with these medications, headaches, nausea, and abdominal discomfort. These usually go away within the first 1 to 2 weeks. Go through warning signs. Sometimes these medications, it's very rare, but will trigger worsening liver function and potentially liver failure. Again, very rare, but telling the patients if they notice any yellowing skin or eyes. This is called jaundice, nausea, vomiting, severe abdominal pain, or change in the stool or urine color. They need to call us right away or go right to the emergency room. This is something that needs to be handled right away. And then we go through the care coordination process, next steps, with how long the labs will take, how long the prior authorization process takes, and then kind of their treatment timeline and how we're going to get them their meds. So you've done all your labs and the patient's gone. And so you're starting to get your labs back to determine A, whether we can treat this patient in primary care, and then B, what therapy should we choose. So this is the general guideline that's recommended for treatment in primary care. Those who are eligible are adults with chronic hepatitis C who do not have cirrhosis, who have not received prior treatment, and who do not have co-infection with hepatitis B and or HIV. So if that's your patient from these labs, then you can go ahead and treat in primary care. Again, on the right, those who are not eligible: cirrhosis livers, prior treatment, fibrosed livers, HIV or active hepatitis B, no treatment during pregnancy, no treatment if there's liver cancer or a prior liver transplant. The reason we can treat with cirrhosis or fibrosis is when you treat hepatitis C when somebody has a really unhealthy liver, their risk from that treatment and from the virus impact, they're at a pretty increased risk for developing hepatocellular carcinoma following treatment, and they actually need to have every 6-month serial liver ultrasounds to monitor for liver cancer, and that has to be lifelong after treatment. So these patients with cirrhosis and fibrosis are best referred to a liver specialist so they can plan for the treatment and then plan for those follow-up scans. So you get your labs back. I'm not going to go again through all this, but verifying that they do have an infection. The genotype, the medications that we're using now are what we call PanGenotypic. You can have any genotype and they work. This used to not be the case. So we kind of are going away from the genotype. However, the prior authorization still does require it. And it is important information to know should the patient fail therapy in the rare chance. So we still run this. Looking at their liver function, making sure their liver is not, in acute hepatitis with a huge increase in your LFTs. A mild to moderate elevation is common with chronic hepatitis C, and it's fine. You can, go on with treatment. This should resolve once you get rid of the hepatitis C virus. We also look at the platelets, bilirubin, INR, and sodium, making sure there's no other dysfunction. And then infectious disease, HIV, if they're positive, we refer to infectious disease. They can do the co-management of these two illnesses. Same with hepatitis B. And then hepatitis A and B, if they are non-immune, we do offer the boosters. And that can be done during treatment. It's fine. It's good to protect the liver at that opportunity. So these indirect liver assessments, the FibroSure is a serum biomarker. It's an indirect measure of liver fibrosis. So it's using these 5 different substances in the body. 3 are kind of labs that you probably have noticed: the ALT, the bilirubin, and the GGT. And then these 3 other ones, these are inflammatory markers and different byproducts of the liver. And when you begin to see these in higher levels, that means there's some necrotic or fibrotic activity happening in the liver. So it uses that and it compiles a score 0 to 1. These scores relate to a Medivir score, which is the gold standard for liver biopsy. And so you can see the fibro test, which is the FibroSure score on the left. Your F0s through F2s, those are your lower level of liver dysfunction and fibrosis. These patients are okay to manage in primary care. When you start getting to F3 and F4, insurance requires that their hepatitis C medication come through a specialist like a hepatologist or an infectious disease provider. We use this thing called the APRI. This is kind of an indirect measure. When we use this with the FibroSure, it gives us more clinical data to rule out cirrhosis and fibrosis. This uses patients' labs, their liver function, and their platelets to determine their risk of severe fibrosis. So it's this calculation we use. You can see it there. We also do the same thing with the FIB4. This is another calculation that uses the patient's age, their liver function, and platelets to to check for fibrosis, severe fibrosis. So the APRI is more suggestive of cirrhosis. The FIB4 is for fibrosis. So these three, the FibroSure, the APRI, and the FIB4, those all look good. And the FibroSure is F0 to F2, then we usually can proceed with treatment in primary care. All the prior authorizations also ask for this MELD score. It's a model for end-stage liver disease. It's most notably used for liver transplant patients. This is a way they tier liver transplant patients. It predicts a 3-month survival mortality risk, integrating these patients' labs. And so scores range from 6 to 40. The higher the score, the greater your risk of mortality from liver disease. You can see this graph here. Once your MELD goes above 20, you see just a dramatic decline in your survival rate. And so for these patients with non-complicated liver disease, their MELD scores should be 6 to 7. You should not really see a MELD over 10 for the patients you'll be managing in primary care. So this goes over everything I just said. If your FibroSure is F0 to F2, your APRI and your FIB4 are not suggestive of cirrhosis or fibrosis, you can go on and treat in primary care. So then we have to choose a regimen. So these are the recommendations for treatment naive adults, so no prior treatment without cirrhosis or fibrosis. There's 2 recommended regimens. We have our Mavorite. This is the most commonly used right now. Then we also have Epclusa, which is a little bit older medication. Mavorite is great. It's 3 tablets once a day for only 8 weeks. It's the only approved 8-week therapy. Epclusa is also really good. It's only 1 tablet once a day, but that one is 12 weeks. Both these regimens are PanGenotypic, meaning that they cover any genotype. And like I said, Mavorite is the most widely covered. So after we choose the regimen, then we need to do a medication reconciliation with the patient's medications. There's this really useful resource from the University of Liverpool called Hep Drug Interactions, and it was specifically made for the purposes of making sure their hepatitis C therapy doesn't interact with any of their other medications. And it also will give you recommendations for what you should do with the medications. Say there's a lot of anticonvulsants that interact with these medications where patients can't necessarily just discontinue them. And so it'll give you an alternative or a suggestion on decreasing dose. Not going to go through all these, but these are the common drug-to-drug interactions for Mavorite. The most common in practice that we have to manage is with statins. These are cholesterol medications that are very common. Your atorvastatin, your lovastatin, and your simvastatin have the highest risk of statin toxicity, and you can get what's called rhabdomyolysis from it. So they really recommend holding that statin during Mavorite therapy to prevent those side effects. You do need to consider the patient's cardiac risk of stopping that statin during that time. So that's a decision that, as a provider, you need to make. There's dose adjustments needed for pravastatin and rosuvastatin. And then the only other thing that comes up really for us and when we treat is the contraception. If they have an ethanol estradiol containing OCP or COC, finding a different alternative for treatment because co-administration is not recommended. Similar for Epclusa, very similar reactions. This one, there is some absorption things with antacids and PPIs that you have to consider. So you've chosen your medication, you've said they're good for therapy. Now we need to send the medication in to your specialty pharmacy. So this is all direct-acting antivirals need to be filled through a specialty pharmacy in Minnesota. And they all do require a prior authorization. Even though they are approved by the insurance company, they still require the step. So the pharmacy will initiate that process. So it's good to have a good relationship with your specialty pharmacist because they can really be helpful when you're navigating this process. And then after you initiate the prior authorization, they'll ask for clinical information, and then they'll submit it to the insurance company for review. So here's the clinical information needed for the prior authorization. I'm not going to go through all these, but it's what med you need, their current medications. There's this provider attestations. This is the place where the PAs most often get denied. So I'll go through some of these details. Then you have to submit that genotype, their pre-treatment viral loads, so the ones 6 months apart, their cirrhosis status, pregnancy status, kidney status, and that MELD score. So here is a screenshot from, this is Minnesota's prior authorization for DHS. These are the provider attestations. So you're, as a provider, signing off that you attest that you've talked about the readiness for treatment, anticipated barriers, and then really are signing off on where they're at with their substance use. Before 2019, Minnesota used to not allow approval of these medications for anyone using drugs that has not been sober for at least 6 months or 3 months while in treatment. They've gone away from that now since 2019 legislator passed, where people can be actively using during treatment, but there are some steps you have to follow to cross some boxes on this prior authorization. So sobriety requirements: if a patient is using but is enrolled in a substance use treatment program, all you have to do is the provider just needs to attest that they are in a substance use treatment program. This can be on the form and or in chart notes. And then this usually does require a negative urine toxicology screen within 3 to 6 months of the PA. If they are actively using or not in treatment and are using, you do have to provide these two things. You have to provide documentation that there has been counseling about the risk for transmission and future infection. And then you have to offer them 2 harm reduction services from this list: condoms, sterile syringes, Narcan, or referral to Suboxone or methadone. The tricky thing about this is the documentation. They need to see that you've offered these things, but we don't usually write prescriptions for condoms or Narcan or needles. So we have done that and printed out just a copy to show that we gave it to them. Or you can also provide your clinic policy for Narcan or syringe distribution or any educational materials. So if your PA is approved, your insurance company will notify the pharmacy and the patient. Sometimes the insurance will mandate the fill at a different pharmacy than you sent it. Your specialty pharmacist should help you with that transfer. And then a big hiccup is that some pharmacies do require the pharmacist to speak to the patient prior to dispensing or delivering the meds. This can be a problem when you're working with somebody who doesn't have reliable access to a phone or is maybe unstably housed. So I do try to coordinate this while the patient is in the office if I'm able. And then we usually end up coordinating delivery to the clinic for them to pick up if they don't have a stable address. And then pharmacies will only dispense 1 month of medications at a time. They won't dispense the full treatment course because of the cost and if people fall off. And so you do have to consider coordinating that refill at the end of 1 month. If the PA is denied, this has been happening quite a bit. Do check with your specialty pharmacy. Their benefits navigator should be able to tell you why it was denied. Sometimes it's just as easy as submitting another lab result that you forgot or providing additional documentation. If it is a true denial, then you can write an appeal letter. And that is kind of a lengthy process. And your, again, specialty pharmacy should be able to help. Kind of outlines the importance of a good relationship with a specialty pharmacy. So starting treatment, they have their medications, they're ready to go. We usually have the patient call us before they take their first dose of medication. We'll have the nurse run through just the basics that they need to take it at the same time every day. If it's MAVR, taking it with the first full meal of the day will prevent side effects. Going through missed dose policy, if it's more than 18 hours since their dose was supposed to be, they should just wait and take their next scheduled dose. They shouldn't take 2 doses close together. Reviewing side effects, they can take ibuprofen or Tylenol as needed for the headaches. Some people have concern about taking Tylenol during treatment. However, the studies do show that you can take Tylenol if needed, just not to exceed 2 grams a day. So when they start, I schedule them for their 4-week follow-up. After they've done a month of treatment, it's good to do labs on the patient. We'll have them come in, we'll check for side effects, any compliance issues. We'll check their viral load at that time. Most patients that you'll be treating with non-cirrhotic livers should clear that virus within the first 4 weeks. If they don't clear it, it doesn't mean it's not going to work, but you do need to monitor them more closely. It can be kind of exciting for patients when they clear it at this 4 weeks. They still need to finish the rest of their treatment though. We also check their CBC metabolic panel just to make sure there's no impact on the liver. and then coordinate their refills of the medication. So after they get their second month, we tell them to finish off their medications, and then we schedule them 12 weeks from when they take their last dose of medication. We call this their SVR, or sustained virologic response visit. If they come in, we check their viral load at that 12-week marker and they're cleared. This confirms that we have cured the hepatitis C and we've eradicated the virus, and they can go on with just routine hepatitis C screenings and, doing your harm reduction education to prevent future infection. And then if there was any abnormal liver labs on the labs you did, you can follow up on those. Sometimes the fibrosure, those inflammatory markers will be off. You don't necessarily have to recheck them if their liver function normalizes. The fibrosure is pretty expensive. And so if there's still some elevation in the LFTs after they're cured, then you do have to look into that further. And then again, coordinating those ultrasounds if a patient's cirrhotic or fibrosed after treatment. Sorry, I know we're running out of time. I'm gonna just 2 more slides left. Indications to discontinue. This is very rare. We've never had it happen yet. If their 4-week RNA, when you check, is elevated, that's okay. Doesn't mean they're gonna fail treatment, but you should have them come back at week 6 and check. They say if there's an increase from week 4 to week 6 in their viral load by more than 1.0 log, that you should stop therapy. That means there has been treatment failure and they should be referred to a hepatologist for management. If that 12-week, that final check is detectable, that means they have failed treatment. And again, they should be referred to hepatology or infectious disease to discuss kind of a salvage therapy. There's other options available to treat. If during the treatment, your patient gets sick, gets that jaundice, is not feeling well, and you see that their ALT is increased more than 10-fold from their baseline, that's another indication to stop treatment. That means that their liver is being impacted by some sort of medication toxicity. Monitor them closely, get them to a liver specialist. And then again, if the ALT is less than 10, but they're having any symptoms of liver dysfunction, they should also stop and be referred to hepatology. Again, very rare, but something to know. The last slide here is just about ways that we've addressed different treatment barriers. We use nurse care coordinators to do this work, and it really involves a lot of care coordination. I like to call patients about a week into treatment to check in, see how they're doing at home, seeing if they've missed any doses, any side effects. We don't want patients to quit their medications because of side effects. So if there's anything we can do with how they're taking it, making sure they're taking it on a full stomach with Maverit to get them through those side effects is really important. We offer to deliver and pick up medications to the office for people who don't have permanent addresses. We use medication minder tools, pill boxes. We'll sometimes have done for patients who are worried about stolen medications. We'll give them a week at a time and store the rest of their medications at our clinic in a locked box. And then finally, you can coordinate their treatment with medication-assisted treatment programming. If they're doing daily dosing, if they're going to inpatient treatment, these can be really good times where patients are in a stable environment to get this treatment done. This is why they're actually starting to treat more hepatitis C within the jail and prison system in Minnesota, which I think is great. And so we're seeing that more often. It can be a consideration that you can do for your patient as well. All right, that was a lot of information. Please go back in my slides if you have any questions, but if you guys have any questions right now, I'd be happy to answer. I know we're running out of time, so thank you.
Could you turn off your screen share, Jay, so
Oh,
we
yeah.
can see? Yeah. Does anybody have any questions for Jay? So it was a very comprehensive review. Very much appreciated.
Yeah, no problem.
Also questions from anyone? I guess I would just make a comment that it can seem very intimidating to take on something like this. It makes such a difference, though, especially for our patients who are, struggling with housing and chemical dependency and mental health things. A lot of them do not feel comfortable going to a specialty care, or just as it seems too overwhelming for them. So to be able to offer this is such a benefit and so important. And again, just sort of getting a little bit organized and having the information together. And I have to say though, having nurse care coordination to help with this, especially as just all aspects of it, especially the prior authorization process, really makes it doable.
If I can just mention quickly, sometimes when the medication request is denied, if you present a case to the viral hepatitis echo, we can provide you with a case summary that oftentimes covers that.
Wonderful. Thank you. That's a resource.
That's really good to know.
Like, it can be very frustrating when that happens, because yeah, you think you have all your ducks in a row and you're kind of leaving it in the hands of the insurance company. So that's really good to know. Thank you. And then, yeah, it can be overwhelming. Using those guidelines that I referenced at the beginning of the presentation is where we kind of learned most everything. And then there's some training modules from the University of Washington, hepatitis C. They also have HIV treatment modules. They're excellent. They're very comprehensive and you can get CMEs from them. And I recommend those as well, if anyone's interested in pursuing this more. And then, yeah, please email me if you have any questions. I would be happy to answer any.
Thank you, Jace.
Yeah.
So we are actually out of time. So please join us next time when we're going to be talking about wound care. And for I forget the exact title, wound care in unsheltered community with Genevieve Utley from Healthcare for the Homeless. And that is on, what's the date?
September 1st.
September.
Thank you. All right. Thank you all for joining us. Have a
Thank
great
you.
day.